Hi, this is Dr. Sham, and this lecture is going to be about DKA, and I'm going to make DKA super easy for you. So let's start with the pathogenesis. So the first thing is that we know that is our cells, they utilize the glucose and they produce energy. But to utilize these glucose, the cells need insulin. When there's no insulin, the glucose is there, but the cells cannot utilize the glucose. So what they do, they utilize the fat. What I mean by do is fatty acid oxidation. And as a result of fatty acid oxidation, what's produced? Ketones. And when the ketones build up in your body, that is called ketoacidosis. And that's what exactly happens in the DKA. Your blood becomes acidic. Let's go a step ahead. Now, if we talk about the symptoms of the DKA, it's dehydration, okay? It's nausea, vomiting, abdominal pain. So how does this happens? So first of all, dehydration, we know. How the dehydration is produced? We know that osmotic diuresis because of the high glucose, okay? The high glucose, it leads to osmotic diuresis leading to dehydration. Now the second thing is that you have ketones in your blood. So these ketones, they go into the urine, and along with that they take the sodium and the potassium. So when they take the sodium and the potassium, so the sodium and the potassium, they will become low. So low sodium and potassium lead to nausea and the vomiting. Now the third thing is that the patient comes with abdominal pain. That's abdominal pain. That is in 12% of the patients. How does that happens? Okay, it's proposed that acute hyperglycemia induced impaired GI motility that leads to abdominal pain. And the second thing is that the dehydration, okay, itself, it leads to the mesenteric ischemia, and that leads to the abdominal pain. So you are having dehydration, the patient is having nausea and abdominal pain. So these are the symptoms of the DKA. The type 1 diabetic, most of the times their usual first presentation is these symptoms. Okay, that is diabetic ketoacidosis. Now the thing is that what's the criteria for the diabetic ketoacidosis? So you need to look at these things. The pH should be less than 7.3. The bicarb should be less than 15 millimoles per liter. The glucose should be greater than 11 millimole per liter or greater than 250 mg per deciliter. And they should be ketonemia greater than 3 millimoles per liter. And we check these ketones in the venous blood. Or if you don't have, then go for the urine ketones, but they should be more than 2% on a dipstick. So that's a criteria for the diabetic ketoacidosis. Now, the next thing is that what's the management of diabetic ketoacidosis? So the first thing is the patient is dehydrated. The first and the foremost and important thing is to give the patient the normal saline. That depends on if the patient is hypotensive or not. If the patient has less than 90 BP, then you give a 500 ml of bolus in 15 minutes and you reassess. If still hypertensive, give another 500 ml of bolus. If the patient is not hypertensive, a simple regime could be that give 1 liter in the first 1 hour, then the next liter in next 2 hours, next 1 liter in next 2 hours, next 1 liter in next 4 hours, and next 1 liter in next 4 hours, and another liter in next 8 hours. So you can see that total 6 liters of the fluid we have given this way. Normally a patient in the DKA is 100 ml per kg deficient. So if it's a 70 kg male, it's 7 liter deficient. 60 liters is 66 liter deficient. That's a proposed rough estimate of that. So that's how you can give the saline. Okay, so you need to give a normal saline, that is 0.9%. The next thing is you need to give the insulin because patient is hyperglycemic. So how we give the insulin? 0.1 units per kg. So if you calculate that, so for a 60 kg man, it's gonna be 66 units. For 70 kg, it's gonna be 7 units per hour. Okay, you give the one in an infusion form, 7 units to a 70 kg man in an hour. And the next thing is that if you're going to give the insulin, you know that the insulin is going to shift the sodium inside the cell, causing the hypokalemia. So you give the potassium, but you do not add the potassium in the first bag. Okay, you add in the second one, and then according to the potassium, okay, in your VBGs, you check, okay, and you add the potassium. If the potassium is greater than 5.5, you need not to add the potassium in the normal saline. If it's between 3.5 to 5.5, then add 40 millimoles in every liter of the 0.59% normal saline, but you keep on checking and then you titrate it accordingly, that either you have to add or you don't have to add. If, say for example, the potassium is less than 3.5, then you need some more potassium and you need to be very vigilant, and maybe you need a HD or ICU care because of the higher doses. Now another thing is that this patient is dehydrated, so it's a hypercoagulable state, DKA. So you need to give a low molecular weight heparin as well if it's not contraindicated. So that is the management, and that's how you give the saline and the potassium and the insulin. Now the important thing is that when you are going to stop the insulin, another question is that how are you going to get to know that you are going in the right direction and now you need to stop the treatment? Very important question. Let's go to that. So the next thing is that how are you going to get to know that you need to stop the insulin and stop the treatment, and whether you are going in the right direction or not? So check if your ketones, okay, are dropping by 0.5 millimole per liter per hour, your bicarbonate is increasing by 3 per liter per hour, and your glucose is decreasing by 3 millimoles per hour per liter per hour. This means that you are going in the right direction. If not, then you need to increase the dose of the insulin. How are you going to increase the dose of the insulin? You need to increase it by 1 unit per hour. Say for example, you are not achieving this goal. Okay, you're not achieving this goal, so you need to you were giving the insulin by, say for example, 7 units per hour. Now you need to increase it to 1 unit, 8 units per hour, and you keep on checking. This is how you're going to monitor that your treatment is going in the right direction or not. Going to the next, continue the insulin infusion, okay, until unless your ketones are less than 0.6 millimole per liter, your pH has now is greater than 7.3, and your bicarbs are greater than 15. Okay, you need to continue. Once you have achieved this target, now you can switch to the subcut. Okay, but you need to administer subcut insulin 2 hours before stopping the insulin infusion. Okay, that's how you're gonna check, okay, that whether you are going in the right direction or not. And then when you need to stop the insulin infusion, when you achieve this target, and you need to administer subcut insulin 2 hours before stopping infusion. One very important point over here is that you might be aware of that when your sugar levels are less than 14 millimoles, okay, then 14 millimoles. When your sugar levels are less than 14 millimoles, to avoid the hypoglycemia, we run 10% of the dextrose along with the normal saline. Don't stop the normal saline, but you run along with the 10% of the dextrose. This is because you are giving the insulin infusion, so there are the chances of the hypoglycemia. So what you do that you run at 10% dextrose along with that. Okay. Now, the last thing is what could be the complications of diabetic ketoacidosis. The first thing is it's dehydration. We know that leads to thromboembolism. That could lead to, because that's a hypercoagulable state. The second thing, hypokalemia. We know it is one grave complication is cerebral edema. Again, here the patient starts dropping the GCS. So get help if sudden CNS decline is there, and if that's there, yeah, another complication could be aspiration pneumonia if the GCS is gonna down. Others are hypomagnesemia and hypophosphatemia in addition to the hypokalemia. So this is how the, you manage the diabetic ketoacidosis.